Hello, my name is Dr. Ghafran Alabi. I'm currently a Foundation Year 1 doctor based in the Northwest, and I'm interested in GP as a career in the future. Today, this podcast is about my article, Challenges to Confidentiality in GP Consulting, that was published in the InnovAiT journal. Firstly, I would like to thank my supervisor, Dr. Neil Metcalf, who is a GP who supervised this project and guided me with the publication of this article. I started this project at the end of my 5th year of medical school as part of a QEPEP, a Quality and Evidence Personal Excellence Pathway, which is part of my medical school's curriculum. This QEPEP was based on professionalism and law in medicine. Today in this podcast, we'll discuss why this topic is important, how it is relevant to general practice. We'll also talk about when confidentiality can be breached, what to do if we have to breach that confidentiality, and where to go for support when we're not sure. I chose to look into confidentiality as a topic specifically, as we all know it is the cornerstone of any doctor-patient relationship. It is a topic that is emphasized to us throughout undergraduate studies, and it continues to be reinforced in our postgraduate careers. But while the theory can feel very clear-cut, real-life clinical scenarios I feel are rarely black and white, and they're often quite complex and nuanced. For GPs and GP trainees in particular, confidentiality is especially important. General practice is built on continuity, trust, and long-term relationships with patients. Often patients have the same family doctor for years and years. And if trust is undermined, it doesn't affect one consultation. It can impact the doctor-patient relationship for years. And that's exactly why I think it's worth talking about. Now, in general practice in particular, there are unique pressures that make maintaining confidentiality more difficult. We're all aware of the increasing systematic pressures on general practice, which often means there isn't enough time to assess these situations as we'd like to if we come across them and manage them appropriately. On top of that, the nature of GP means you're often treating patients from same families rather than people in isolation, and information shared by one patient can easily have implications for another. This isn't just theoretical. A data request sent to one of the medical defense organizations, the Medical Defense Union, found that queries related to confidentiality are actually one of the top 3 reasons why members call. And as well as that, a data request I sent to the GMC found that over the last 6 years, 765 confidentiality concerns regarding general practitioners specifically were raised. So this just shows that it is still an issue that continues to affect GPs in day-to-day practice, and it can easily affect any one of us throughout our careers. And that's why I think it's important to continually renew our knowledge on the guidelines and the legal frameworks around confidentiality. Firstly, we're going to go through what the General Medical Council says about confidentiality. The GMC recognises that although confidentiality is a strict duty, it is not absolute. Generally, the GMC states that information can be disclosed if, firstly, a patient has given explicit consent, which is the most obvious and straightforward one. Secondly, if a patient lacks capacity and it's in their overall benefit to disclose information. Thirdly, if the disclosure can be justified in the public's interest to prevent serious harm or death. But before doing so, we need to take into account the potential harm to the patient, harm to the public's perception and trust in the healthcare system if you do disclose, as well as the potential harm to others if information is not disclosed. So there is a lot to balance whenever we have to do this. And finally, if the disclosure is required by law. Now, there are a few common examples of a doctor's legal obligation. The first one, for example, is the Female Genital Mutilation Act, whereby if you find any patient under 18 years old that has been subject to FGM, you need to inform the police. The second example is Prevention of Terrorism Act and the Terrorism Act, whereby police must be informed if you have information that may help them in preventing a terrorist act or prosecuting someone who's already committed an act. I'll now go through one hypothetical scenario that might present to primary care. It's also discussed in the article under clinical case scenario 2. So, for example, a mother has booked in an appointment with yourself as she's concerned that her 19-year-old son, who was recently diagnosed with epilepsy, is continuing to drive against medical advice. He's already established on anti-epileptic medication and was told he couldn't drive for at least 1 year. Hopefully, we should be able to recognise that there is clearly a risk of serious harm or death to both the patient and the public if he continues to drive. For example, the patient could have a seizure while driving and lose consciousness, putting himself and others at risk. However, at this stage, it would not be appropriate to disclose information to the DVLA immediately. as you would be breaching confidentiality. In the article, we go through one way that we could approach this situation. So, for example, we ask the patient to come in for a follow-up. You could either notice, for example, that he comes into the clinic room holding car keys, or you could ask him how he got to the practice. It'd be our duty to explain to the patient the rationale for not driving and the risk if he continues to do so. However, say, for example, he is not happy to stop driving. This is where we consider breaching confidentiality under the principle that we are justified in disclosing information in the public's interest to prevent serious harm or death. Now, if confidentiality has to be breached, patients should always be told about the anticipated disclosure of information, even if you anticipate conflict or hostility from the patient. As well as that, always document the disclosure in the patient's records and why the disclosure happened. The GMC advise in their guidance relating to reporting to the DVLA specifically to write to the patient after the disclosure, and I don't see why that recommendation can't apply to any breaches of confidentiality as part of good, transparent practice. Hopefully that scenario was useful to see how we can apply the guidelines to a practical scenario. I'm just going to highlight some key points we talked about today. Firstly, confidentiality is an essential component of good medical practice, and we have a strict duty to uphold it, and we must not take the responsibility lightly. We've also briefly discussed the GMC guidance on confidentiality. We've also discussed if we're going to breach confidentiality, it must be done responsibly with careful consideration, and patients should always be informed about the anticipated disclosure. And finally, continuing to learn and refreshing our knowledge on confidentiality is essential to navigating these dilemmas safely and professionally. I'm going to go through some useful resources for further reading and support. The GMC has an extensive document called Confidentiality, Good Practice in Handling Patient Information, as well as 6 additional documents relating to specific scenarios that we go through more extensively in the article. For example, disclosing information about serious communicable diseases, such as HIV, or disclosing information to employers or insurance companies. And the guidance sets out expectations of us as healthcare professionals. The BMA also have an ethics toolkit on confidentiality, which is a useful PDF from the British Medical Association. We can always seek support from supervisors and colleagues as well in uncertain situations. And finally, defence unions can offer medical legal advice and support if we're faced with these scenarios. That brings us to the end of the podcast. I hope it was useful, and thank you very much for listening.